everyone, and welcome. Today, or for now, we're going to talk about sedation, analgesia, and delirium in the ICU. Let's talk about pain. The incidence of severe pain in the ICU is at least 50% in surgical and medical ICUs. So it's very common. Procedural pain is common, and inadequate treatment is a common problem. So people have pain, but we don't adequately treat it. Pain has been identified as a leading cause of inability to sleep in the ICU, which leads to other things such as delirium and worsened mortality for these patients. Studies show that 82% of patients who are still in the hospital remember having pain associated with being intubated. 77% remembered moderate to severe pain associated with their ICU stay. 82% of cardiac patients reported pain as their most traumatic memory 1 week after discharge. And 6 months later, 38% of these patients still reported that pain was their most traumatic memory of being in the ICU. Let's talk for a minute about post-traumatic stress disorder and ICU pain. So there was a study that was done that was 6 months after an ICU stay, and 17% of the patients remembered experiencing severe pain, and 18% of those were at high risk of developing PTSD. When compared to the norms, both medical and surgical patients who remembered pain had an increased incidence of chronic pain at 38%, PTSD symptoms at 27%, and lower health-related quality of life at 21%. So this pain that the patients experience while they're here really can affect their lives forever, so you need to remember that when treating these patients. Let's talk about for a second what pain does to the body. So when a patient has pain, they have a stress response. This stress response leads to arterial or vasoconstriction, impaired tissue perfusion, and reduction of tissue oxygen partial pressure. And it also causes a catabolic hypermetabolism that leads to hyperglycemia, lipolysis, and muscle breakdown, which we all know is really bad for these ICU patients and is a problem that they have related to their disease processes as to why they're here, and we're making it worse. Also, pain can suppress natural killer cell activity. So it decreases the number of cytotoxic T cells and reduces neutrophil phagocytic activity. So basically, we're causing these patients more stress by not adequately treating them. So how do we measure pain? So pain assessments are done every hour by the nurses in our ICUs, and the gold standard for our measurement of pain is the patient's report of pain. It should occur in all ICU patients on a regular basis. Like I said, we do it every hour here, and you shouldn't use vital signs as your sole source of a pain assessment. However, they can help you to know that if they're hypertensive or tachycardic, that maybe there's something else going on. There are many reasons for those things in the ICU, which is why you should not use it as your sole assessment. But it can help you to understand that a patient who says they have 10 out of 10 pain does have 10 out of 10 pain. But it does not mean that the patient who's sitting there with a heart rate of 80 and a normal blood pressure does not have 10 out of 10 pain. And then we use behavioral pain scales, such as the adult nonverbal pain scale, which can be used in intubated patients to assess their pain. And these have been shown to lead to shorter ICU stays and shorter durations of mechanical ventilation when used appropriately. You can see in the picture on the bottom of the screen how you use these adult nonverbal pain scales. The numbers are 0 through 10 from left to right. If your patient can report, you want them to report on a 0 to 10 scale, but you can also use it in intubated patients to assess them based off of their verbal cues and agitation. So now I've determined that my patient has pain. Now what do I do? So you have many, many options of medications. I've listed some here on the side. Fentanyl, morphine, methadone. We don't prescribe this in the ICU unless they take it at home. Zolotid, remifentanil. We don't use that either really in these ICUs. But remember when you're picking which one that you can only give it orally if their gut works. Many of our patients have open abdomens. Many of our patients have had bowel surgeries. And many of them, their bowels just don't absorb. So keep that in mind prior to writing for oral narcotics. Also remember that all of the intravenous narcotics that we give are equally effective when titrated to the same endpoints. Meaning if you use Dilaudid, or if you use fentanyl, or if you use morphine, if you give the correct dosages for the patient and their pain is improved, they're all equally effective. There's not one that's better than the other. Also pick the drug based on the patient for which you're treating and consider the pharmacokinetics and pharmacodynamic properties of those. You don't want to give, something that's renally excreted to somebody who has end-stage renal disease, and bear that in mind because you can build up and get toxic, and that's really bad for his patients as well. And remember that neuropathic pain is not treated by opioids. So in a lot of these vascular patients, for example, that have neuropathic pain from their poor perfusion, IV opioids won't really help them. So you want to consider things like Neurontin, but you can only give those if the gut works. This table shows the dosages of medications that we use, and again, like I said, methadone is also on this table, but that's a drug that I wanted you to know about, but that we don't really use in the ICU unless the patient is on it at home. But the fentanyl and the Dilaudid and the morphine, we use those more frequently. This tells you how fast the onset is, what the half-life is, and again, the PO dosages, we do use PO Dilaudid from time to time, and from time to time we use PO morphine, but again, only if the gut works. I can't stress that enough. And then it tells you the dose equivalencies. So 0.1 milligram or 100 mics of fentanyl is equal to 1.5 milligrams of IV Dilaudid is equal to 10 milligrams of morphine. So just remember when you're dosing them those equivalencies so that you're giving the right doses to these patients. This slide shows how you do intermittent dosing or IV infusion rates of these medications. We use fentanyl infusions is what we use here, and we have an order set for that has the dosages in it, but the infusion rates are on here for all of the medications depending how you use them. And again, with the methadone, it's here for your benefit so that you know what it does to people who come in who take it at home. But remember that fentanyl can accumulate in patients with hepatic impairment, so be careful in the liver patients over on 4 East. In Dilaudid, it can accumulate in both hepatic and renal impairment, and morphine also accumulates with both hepatic and renal impairment. So many of our patients have AKI related to sepsis, and many of them have liver dysfunction. So just be cautious when you're dosing these medications and know that they can build up in the system, and although they might be fine right now, with the more dosages you give, the more likely they are to become toxic on these medications, which again is not good for our patient population. If a patient comes in on methadone, just remember that you need to monitor their QTC because QTC can be prolonged in methadone, and we'll talk about QTCs here shortly. But that's something that you need to check in these people who take methadone at home and come in. It's always better to use non-narcotic pain relief than it is to use narcotic pain relief. You can decrease the side effects of the opioids. Non-narcotic pain relief causes less gut problems, less constipation, less nausea. And we use things such as local and regional anesthesia, epidurals, and paravertebral catheters. Paravertebrals are often used in the patients who have rib fractures to decrease their narcotic use. You can also use nerve blocks in patients who have had femur fractures or other things that are locally able to be treated with a nerve block. And then we use epidurals a lot in the patients who have big abdominal surgeries. Although Toradol and ibuprofen are great, the NSAIDs need to be used carefully because they increase your risk of bleeding, and this is mostly a surgical population, so please don't prescribe these without speaking to the primary service before prescribing them. IV Tylenol is a great drug. It's often given in the operating room, and we actually have limits on who can get it. You have to only give it within the first 24 hours of surgery. But remember with IV Tylenol that if it's administered quickly, it can cause profound hypotension. So you must be careful in the administration of this, and you don't want to give it to somebody who's already hypotensive on pressors. But all of these things can be used to reduce opioid requirements. However, the stipulation of this is that they haven't really studied non-narcotic pain relief in the ICU populations. So there's no evidence that it's better, but we know based off of other studies that it is better because it does less harm to the patients. This table has a list of the non-opiate infusions that we use here, or PO or IM medications that we can use. Ketamine is a drug that you can give IV. When you give ketamine, it can cause tachyarrhythmias, so you need to be cautious as to pushing it. We usually use ketamine infusions if we're going to use ketamine. Ketamine dissociates you, and we'll talk about that more in a minute. You can use PO and PR Tylenol. You can use the IV Tylenol as we discussed. Toradol, again, is an NSAID, so you need to be careful in the patient who can be bleeding. Ibuprofen, also in patients who are bleeding, you must be cautious. And then Neurontin is great for neuropathic pain, and you'll see this used frequently in the ICU. So this tells you the dosages and the side effects and other information you need to know about these non-narcotic pain medications. So ketamine attenuates the development of acute tolerance to opioids, and it actually can make you kind of reset your pain receptors where you're able to have less dose of narcotic to treat your pain. But it can cause hallucinations because it disassociates you, and it can cause tachyarrhythmias. Tylenol, of course, please don't give it to the liver patients. They can't metabolize it. You can give that PO or IV. Toradol, don't give it. If the primary service tells you you can give it to a patient, don't give it to somebody who has renal dysfunction because they can't clear it. Don't give it to people who have GI bleeds, platelets abnormalities, if they're taking ACE inhibitors, CHF cirrhosis, or asthma. Ibuprofen, the side effects and precautions are the same as the Toradol. And then for Neurontin, remember that Neurontin does cause some sedation, and it can cause some confusion and dizziness. If the patient has renal failure, you have to adjust the dose. And it can cause withdrawal syndromes. When you stop it, they can have seizures, but this is with prolonged use. So let's talk for a minute about ketamine. So ketamine's mechanism of action is it antagonizes the NMDA receptor, which is the calcium channel, and the channel is linked to the phenomenon of central sensitization, which is associated with the development and maintenance of chronic pain. Again, it kind of helps reset your pain receptors. It appears to reduce that level of sensitization. It also works on nicotinic, muscarinic, and opioid receptors, and it's been shown to reduce post-surgical pain. It's very, very useful in patients who are opioid tolerant, such as those who take methadone at home, and now you can't give them their enteral methadone because their gut doesn't work. And so you can use ketamine to treat those patients, and it's very helpful for that population. Be very cautious in patients with tachyarrhythmias and patients who have increased secretions because it can worsen tachyarrhythmias and it actually can increase their amount of secretions. So not the best drug to give to somebody who's in AFib with RVR. Clonidine. So you'll see clonidine patches used a lot in our ICU to treat pain. They are an alpha-2 adrenergic receptor agonist. They're usually used for hypertension, but they've been shown to be helpful in drug detoxification, pain relief, and sedation. So you can use this drug for many reasons. It works really well for chronic pain and for neuropathic pain, and it can have opioid-sparing effects when used in acute pain. So basically, if you put a clonidine patch on somebody, they should, in the right dose, they should need less narcotics to treat their pain. It also can have anxiolytic effects due to reduction in catecholamine release, and they're very widely used in German ICUs as an analgesic. We don't use them as much in ICUs here in the United States, but there's lots of good research and good studies that prove that they're very helpful. Only thing with clonidine is to be very careful because they can make your patient hypotensive. So it's better to start with a lower dose and go up, especially in a patient whose blood pressures are, in the 120s to 130s. You don't want to put a 300 mic clonidine patch on them and then them become hypotensive. Ropivacaine. So ropivacaine is what we use in the nerve blocks and the epidurals generally. It causes a reversible inhibition of sodium ion influx, which leads to blocked nerve fibers. It's less lipophilic than other blocks, so it causes less motor blockade than other medications, and that's why we prefer it. It's metabolized extensively in the liver, so you have to be careful in patients with hepatic impairment, and the kidney is the main excretory organ. It's generally well tolerated, but as far as side effects go, they can cause hypotension, which is by far the most seen side effect here in the ICU, nausea, vomiting, bradycardia, and headache. The hypotension happens quite frequently, and the best thing for you to do when you come across a patient that has an epidural, it's usually an epidural, is to call the acute pain service and have them adjust the dosage of the epidural, because if you just shut it off, their pain will be really high, but sometimes you can find a spot with the dosage that allows the patient not to be hypotensive and for the pain to be controlled. Also make sure before you turn it off that their volume resuscitated and all of those things, and look for bleeding and other sources of the hypotension. The adverse effects, as I said, they're generally dose dependent, and you can use them in any of the blocks that we use, epidurals, paravertebrals, and peripheral nerve blocks. So let's talk for a minute about pain medications and procedures. So you're doing a procedure, should you give the pain meds first? Well, let's look at the data. Less than 25% of patients get a pain med before a procedure. Seems like a very small portion of patients that are treated prior when we know the procedures are going to be painful. But preemptive analgesia has been shown to be beneficial. Also remember that you can use non-pharmacologic methods of treating pain. You can use distraction, you can put the radio on, you can sing to them if that's your thing, but remember that these patients will have pain associated with these procedures, and you don't want them to remember that and develop these chronic problems that we discussed earlier because we didn't appropriately treat their pain. Now let's talk about agitation and anxiety. These things are very common in the ICU. It's a scary place. It's a scary place for patients. It's a scary place for their families. And agitation and anxiety have been shown to cause really bad outcomes in these patients. So if a patient is agitated or anxious, first of all, you need to treat the underlying cause. What is making them agitated or anxious? It might be something as simple as being in the ICU, but there are medical problems that also can cause agitation and anxiety. So you want to look for things like delirium, pain, hypoxia is a big one, hypoglycemia is a big one, hypotension, withdrawals, those sort of things. And if you can treat those to treat their anxiety and anxiety and agitation, that's the best way to do it. You can reduce their anxiety by reorienting them. You can give them pain medications. You can maintain their sleep patterns so that they don't get delirious. But you need to try everything else before giving sedatives. Don't just say, okay, this patient needs some Versed, because we'll talk about Versed in a minute, but that's not good for them either. So we've tried all of those things and you're still agitated. Now what do we do? So light versus deep sedation. So deep sedation is very bad for patients. It has negative consequences. If you lightly sedate somebody, they have decreased ventilator days and decreased lengths of stay. Let these patients wake up. It is okay for them to be awake and move around. Light sedation has been shown to increase the physiologic stress response when they wake up and they're anxious, but they did a study to look and see if it actually affected the patients and their myocardium, and they actually found that there was no increase in the incidence of MI in these patients. So really you are increasing their physiologic stress response some, but it's not enough to actually hurt them. We use sedation scales. The RASS is the most reliable scale to measure the need for sedation, and I have that on the next slide. But you want to minimize sedative use and use non-benzos when able. If you do this, you can improve outcomes, shorten vent days, decrease their length of stay in the ICU and in the hospital, decrease delirium incidence, and decrease long-term cognitive dysfunction that can be caused by using these things all of the time. This is the RASS scale, which is what we use in our ICU to determine whether a patient is agitated or over-sedated. So generally when you have a normal patient, they're a 0, so they're alert and calm. And as you get more and more agitated, it goes up by 1 point, 1, 2, 3, and 4. Clearly you don't want somebody to have a RASS of 4 where they're dangerous, or a RASS of 3 where they're pulling everything out. But a RASS of 1 is okay, and then normally when you sedate somebody, if you're just doing general sedation for like an intubated patient, you want them to be a -1 to 2. Anything more than that, they're over-sedated. So the only time that you sedate somebody into a deep sedation is if they're a TBI or they're on a paralytic, but that's another lecture. So let's talk about some of these sedatives. So you have benzos, propofol, Precedex. How do you choose? Usually you should use non-benzos first. And we pick this based on sedation goals for the patient, the pharmacology of the drug, and the overall cost associated with the drug. So if you have somebody who's in liver failure, clearly you don't want to give them Versed because they can't clear it. If you have somebody who's profoundly hypotensive, propofol may not be the best choice. And Precedex we'll talk about, but you can use that in non-intubated patients, and it's helpful. So benzos, they have anxiolytic, amnestic, sedating, and anticonvulsant effects. Remember that benzos have no analgesic effects. They do not treat pain at all. They might make your patient forget the pain, but they still have pain. Critically ill patients have a very high risk for benzo-induced cardiopulmonary instability. These drugs can cause hypotension. They can cause bradycardia. It's metabolized by the liver. And the active metabolites of Versed can accumulate in the peripheral tissues. So bear that in mind when you're saying that the patient hasn't had Versed in 12 hours, but they're still sleeping. In old people, they don't wake up from Versed quickly, in hepatic dysfunction and patients with renal insufficiency. So these drugs are not benign. And the use of benzodiazepines have been shown to increase ventilator days, increase lengths of stay, and increase the incidence of delirium, which are all 3 things that we don't want to happen in our ICU patients. Propofol. So propofol is sedative, hypnotic, anxiolytic, amnestic, antiemetic, and anticonvulsant properties. Again, it has no analgesic effect. It will not treat pain in your patients. It may make them forget it, but it won't treat the pain. The amnestic effects are higher at lower doses than benzos. So what that means is you have to give more Versed to get an amnesia effect than you do with propofol. It's great because it has a rapid onset and a rapid offset. So as soon as you give some propofol, the patient will calm down, and then if you don't give any more, within a few minutes they'll wake up from it. It's very useful in patients who need frequent neuro checks. This is what we use in our TBI patients. This is what we use in anyone who needs neuro exams. And it's but remember that it has a dose-dependent respiratory depression and hypotension because it will systemically vasodilate you. So when you give propofol, it can, in higher doses, it can decrease respiratory drive and it can cause hypotension. In some of our patients, it causes hypotension in small doses. So remember that in patients on propofol and the nurse comes to you and says that the patient's hypotensive. It can only be administered for the first 6 hours via peripheral access. So if you're going to start somebody on propofol, they need a central line within 6 hours unless they're going to come off of it quickly. The propofol is mixed in a lipid-based formula, and it's very caustic to the vessels. It's similar to TPN and the lipids in the TPN that have to be given centrally. So let's also talk for a minute about propofol infusion syndrome. So propofol infusion syndrome is very rare, but when it happens, it's very bad. There's an incidence of about 17% in patients who receive at least 5 milligrams per kilograms per hour. There needs to be more study about the incidence of it because it is rare, but that's usually how often it happens. The risk factors are the dose and duration of use, carbohydrate depletion, severe illness, concomitant administration of catecholamines and glucocorticosteroids, mitochondrial disease, and sepsis. So if you think about that, all of our patients are at high risk for propofol infusion syndrome in general if they're receiving propofol. So the pathophysiology behind propofol infusion syndrome is that it impairs the mitochondrial beta oxidation of fatty acids and disrupts the electron transport chain. It blocks beta adrenoreceptors and the cardiac calcium channels. So it presents as an unexplained high anion gap metabolic acidosis. The patient can have rabido. They can have hyperkalemia, AKI, elevated LFTs, cardiac dysfunction, and ultimately it can cause cardiogenic shock, VTAC, and asystole. So this is a big problem. It depends on the triggering factor. So if you're getting propofol and glucocorticoids, it causes increased proteolysis, myopathy, rabido, and renal failure. If it's high doses and greater than 48 hours duration, it causes mitochondrial inhibition, increased levels of free fatty acids, and arrhythmias. And if you're given it concomitantly with catecholamines, you get myofibrillar degeneration, arrhythmias, or heart failure, shock, acidosis, and renal failure. So your treatment of propofol infusion syndrome is, of course, to stop the propofol and provide supportive management. If they've gone into renal failure, you need to give them dialysis. If they're hemodynamically collapsing, you need to give them hemodynamic support. But unfortunately, despite the fact that we know about this, most people with propofol infusion syndrome die. So Precedex. Precedex works centrally in the locus coeruleus with a high affinity for the alpha-2 adrenoreceptor, and it has analgesic, sympatholytic, and anxiolytic properties. It does not accumulate with prolonged infusion. Patients are arousable, it's not as sedating, and it causes minimal respiratory depression. Precedex is the least of the evils, but unfortunately it's also the most expensive of the evils. It's metabolized in the liver, and it can prolong QTC, so bear that in mind if you're ordering Precedex, and again, we'll talk about QTCs in a minute. And it's only approved for short-term sedation. It used to be less than 24 hours in this ICU, now it's less than 72, but some research proves that Precedex can be safe for up to 28 days of administration. It can cause hypotension and bradycardia, so be careful in patients who have cardiac disease, they're more prone to it. And it's proven to be effective in extubation and can lower the stress response caused by extubation, thus making it more likely for the patient to do well. So ultimately, these patients who you're trying to get extubated, and every time you turn off their sedation, they become very agitated and they're all over the place and they're not breathing well because they're so anxious. Precedex can help you get those patients extubated without having to trach them. It is the only sedative approved for use in the non-intubated population, so you don't have to turn it off before you pull the tube. You can leave them on the Precedex to keep them calm for some time afterward to give them their best shot. It has opioid-sparing effects, so it can reduce opioid requirements. This is controversial, but there have been some studies that show that it helps with pain. And it also decreases delirium days. And they've also been studying it, just as a sidebar, for use in palliative care to keep these patients comfortable. So, yeah, we talked about RAS, but determining what depth of sedation a patient should be in or how we should measure it, there's no specific consensus on that. We use the RAS here. Other places use other scales. It depends on where you go. But there are common principles that all of the governing bodies agree on, is that you should give adequate and preemptive pain treatment. The thought is that if you treat their pain, they may not require sedation. That's usually what's making them agitated, is the pain. Only sedate them when required. Use valid and reliable assessment tools. Sedation should allow for the patient to respond. They should be aware and should be able to follow commands, not just sleepy but arousable. You want them to be able to follow commands. You want them to be able to wake up. They should have a daily sedation interruption or holiday. The nurses do this every single day. They have to turn everything off for an hour. And in most patients, if the pain is adequately treated, again, you should be able to wean the sedation. Not all patients require sedation to be on a ventilator. Don't forget that. If you adequately treat someone's pain and they're calm, you don't have to give them sedation just because they're on a ventilator. Let them wake up. It'll get them extubated faster. So let's talk for a minute about delirium in the ICU. Delirium is actually quite common. It affects up to 80% of mechanically ventilated adult ICU patients, and it costs $4 to $16 billion a year in the United States. Also remember that delirium is an independent predictor of mortality. If they get delirious, the odds of them dying are substantially higher. And it's an independent predictor of the number of ventilator days. So what is delirium? So the features of delirium are impaired short-term memory, impaired attention, disorientation. It usually develops over a short period of time and has a fluctuating course. And there was a multi-center study that was done that showed that the incidence of delirium is 32.3% in general hospitalized patients. But as I said before, up to 80% of mechanically ventilated adult ICU patients. So this is a real problem, and we need to always keep our eyes out for it. So why is it bad? It increases mortality. It increases hospital length of stay. Delirium increases the cost of care. And there's a high risk of long-term cognitive impairment. So these patients that get delirious in the ICU, they don't necessarily get better, and they may have dementia for the rest of their life because they got delirious here. There are two types of delirium. There's mixed delirium and hypoactive delirium. Hypoactive delirium has a worse prognosis with a mortality rate of 32% at 6 months versus 8.7% in other types of delirium. And the reason for this in most studies that I've read is that we don't diagnose hypoactive delirium very frequently. We always attribute it to narcotics or other things as to why the patient's sleepy, but it might actually be that they're delirious. So keep that in mind in these patients who aren't really waking up and you don't really know why. So the risk factors for delirium can be electrolyte abnormalities, fever, sepsis, pressors, benzos, opiates, anticholinergic, shock, infection, anemia, hypertension, respiratory disease. So basically every patient in our ICU has a risk factor for delirium. And there are some predisposing conditions: dementia, CNS disease, alcohol abuse, older age. Those patients are more likely to get it, but generally we see it across all populations. And the patho of delirium is a little controversial. It's not entirely understood, but you get a decreased cholinergic activity, increased dopaminergic activity. You can have a genetic predisposition. You can have increased serotonergic activity, decreased serotonergic activity, primed microglial cells, neurotransmitter imbalance. We don't really know why it happens. It's not fully understood, and more study needs to be evaluated to determine that. So This slide shows the confusion assessment method, or the CAM-ICU. This is how we determine if a patient is delirious or not in the ICU. And as you can see, it's somewhat extensive. And the nurses do this, I believe, every 4 hours. But it addresses all of the reasons or the features of delirium. So if there's an acute change or fluctuating course of mental status, if you say yes, you would move down. If there's inattention, so the way that they determine that is you spell save heart, you have them squeeze your hand when you say the letter A, and if they can do that, then they don't have delirium, but if they can't, then you move on down the scale. The problem with this is if your patient is sedated, that you can't really do this, and it's hard to do in intubated patients. So you have to use kind of your clinical judgment with those sorts of patients, or maybe lift their sedation to have them do it. But this is how we determine, and if the patient is CAM-ICU positive, that would be when you would want to start a delirium protocol and treat them for delirium. So what do we do about delirium? The best thing to do is prevent the delirium. You want to get them up and let them move. Give them minimal benzos. Lightly sedate them only. Don't deeply sedate them. Extubate them. Best everyone who is appropriate every single day. You want to give everyone the best shot that they have to get extubated. Maintain day and night cycles. You have to monitor at least once a shift. And treatment in the literature is to use Haldol, but it's not really been proven to be safe or efficacious in the treatment of it. And then there's a delirium protocol in EPIC. It's an order set that has the medications that we use. You can give scheduled medications, you can give PRN medications, and it's all in that order set. So what medications do we use? So on this slide are the 3 most common medications that we use: Risperdal, Zyprexa, and Seroquel. Seroquel is actually the most commonly used. However, it only comes in a tablet, so if your patient can't have tablets, then they can't take it. It's metabolized in the liver, and the dosages are there. We don't use the extended release tablet. We use the twice daily dosing in our ICU. Zyprexa can be given as an orally disintegrating tablet, so you can put it underneath someone's tongue if you need to. And Risperdal comes in a liquid form, so that's kind of how you need to choose between these 3 things. But as I said, Seroquel is the most frequently given one in our ICU. The half-life and metabolism are on here. As you can see, the Zyprexa and the Risperdal have rather long half-lives, and the Seroquel has a shorter half-life, so that may also potentially weigh in on your decision as to which to use. So I keep saying QTC, QTC, QTC. Why do we care about a QTC, and what is a QTC? So QTC is a QT interval that is corrected for heart rate. It's a calculated formula. It tells you the QTC interval on every EKG that you order, and it also can calculate it on the bedside monitor. If you tell the nurse you want to know the QTC, they can pull it up and tell you instantly. So a prolonged QTC is greater than 480 in females and greater than 470 in males. But when do we worry? We worry about a QTC that's greater than 500. Why do we worry? So an increased QTC markedly increases the risk of developing torsades and can lead to sudden cardiac death. We need to monitor these in these patients who take medications that prolong the QTC. And unfortunately, we usually use several medications at once that prolong them. So if you're giving them Seroquel and Zofran for their nausea, both of those medications can prolong QTC. So the treatment is to stop the offending agent. There might be more than one agent. Remember that. It's not necessarily just the Seroquel that prolongs their QTC. If they have a prolonged QTC, you need to go through their medication list and make sure that they're not on anything else, such as Zofran, which can prolong the QTC. But the delirium meds are very high on that list. And you want to give them mag sulfate, which helps keep them from going into torsades. Here is a list of some QTC prolonging medications. This list is not exhaustive. You can see the reference there as to where I took this from. But antibiotics, we use Flagyl a lot. Those sort of things need to be looked at. Benadryl can do it. All of the antipsychotics that frequently do it are listed there. Methadone can do it. We talked about that earlier. Zofran can do it. And then lots of the antidepressants too, Prozac, amitriptyline, those things can also prolong QTC. So if these patients come in and they're on some of these medications at home, remember that they might come in with a prolonged QTC to start with. And Haldol can also, that's usually our go-to drug if the patient's very agitated. Just remember that if they have a prolonged QTC and you're giving them IM or IV, we use IV Haldol here. If you're giving them IV Haldol, it can cause them to go into cardiac arrhythmias. So just remember that when you're given these medications. So a little bit, very short, about drug withdrawal. So patients who have long-term high-dose opiate exposure or sedative exposure can withdraw. It can occur within 12 hours of stopping the opiates. If they have long-term opiates at home, you should consider contacting the acute pain service if you can't continue their PO meds. So the patients who have PO methadone at home, you may need acute pain services help to manage their pain. If you use benzos in the ICU for any prolonged amount of time, they have actually an 8.2% withdrawal rate just from being on Versed while they're intubated, or using it intermittently in patients who aren't intubated. But just remember that it's not benign, and when you stop those things, these patients can actually go through withdrawal. And unfortunately, Precedex can also cause withdrawal and has a 4.9% withdrawal rate in patients who have been on it. So let's talk for a minute about protocols. Everything in our ICUs we have a lot of protocols, but remember that only 60% of ICUs have pain, agitation, and delirium protocols, and actually in most that have protocols, the adherence is low, which has been shown to lead to poor outcomes. So you need to remember that these patients are having poor outcomes if you're not following the protocol. You should target adequate pain management and light sedation with minimization strategies. Try not to give them benzos. Try not to sedate them heavily. Try to give them non-opiate pain relief. And you want to facilitate communication between staff. And protocols also help to set appropriate sedation goals. So if you just write for a medication, who knows how sedated the patient will get? You have to give an actual amount of sedation that you're willing, or that's good for the patient so they can still wake up. So unfortunately, despite all of this data that narcotics are bad and that non-narcotics are better and that benzos are bad, pre-procedural pain meds are only used 20% of the time. Pain and discomfort are the #1 cause of stress in ICU patients, and 40% of patients report pain that's moderate to severe, and the incidence of delirium is very high and very inappropriately treated. So when you're looking at your patients, remember to control their pain before you sedate them. Remember that once you sedate them, you need to let them wake up as soon as possible so that they don't get delirious and have long-term effects that can really harm them. And that's basically the gist of what you need to do with the pain. As far as your medications that you choose, remember that it depends on how it's metabolized, and remember the dosages, which you have the tables now, so that we keep these patients awake and moving, because really that's what's best for them. So what can you do? You can make a difference. We must work together to minimize infusions in the ICU. Sometimes IV infusions, like continuous infusions of medications, are appropriate. But be cognizant of what you're giving and what are the effects of what you're giving. Minimize benzo use. Frequently orient patients. Remember that these patients are sedated. We sedate them, and then we wake them up, and they've been sedated for however many days that they've been sedated. Now they don't know who they are, why they're in the hospital. And when they wake up and they're very agitated, sometimes getting them to look at you and telling them where they are and that they had surgery and that you're going to get the breathing tube out, you just need them to cooperate, can really calm them down without ever giving them something else. Make sure that during the day the lights are on and that at night you turn the lights off. These patients need to sleep. Use other techniques besides medication to treat patients if possible. Excuse me. And always explain what you're doing to patients, to families, to nurses. Remember that using non-infusions, using intermittent dosing of medications, that didn't used to be the norm, but it is the norm now. So sometimes when you're asked for an infusion of a medication, like a fentanyl infusion, and you want to give them intermittent, sometimes you have to be patient and explain to the nurse why you're using intermittent. Sometimes the families don't understand why you're not putting the patient completely under general anesthesia because they're intubated. And you have to explain to them that it's better for them to be awake and be moving around. And in general, people are very understanding of that. Here's a list of references that you can look at. Where I got all of my information. You can read these at your leisure, but the first one on here, the clinical practice guideline for the management of pain, agitation, and delirium in adult ICU patients, is where the majority of this came from, and it's actually a really great document to help you. Thanks a bunch. Let us know if you have questions.